Hello, this is Michael Bond. I'm the Residency Program Director for Emergency Medicine, and on behalf of Brian Brown, the Chairman of Emergency Medicine, Michael Winters, the Medical Director for the University of Maryland Emergency Department, I'd like to just give you a brief video overview of our Emergency Department rotation and help orient you to the goals, objectives of the Emergency Department and make your life a little bit easier as you start your rotation with us. So let's start off with just talking about some of the expectations. Your schedule is going to be posted on Amion with the password UMDEM. You should receive an email from the chiefs along with the goals and curriculum of the rotation about 2 months before your rotation starts. Once they mail it to you, you have 48 hours to let them know of any scheduling conflicts. This is really imperative. We work our hardest to try to make sure that you're not coming off an overnight and working on our ED on the first day. But as you can imagine, scheduling is extremely difficult and hard at times, so we need you to do a final check. After that 48 hours, it's going to be up to you, though, to work out switches. So please look for that email, respond quickly, and let them know whether you have any scheduling conflicts. All of our shifts start at 7 a.m. or 7 p.m., so we do 12-hour shifts. And as you can imagine, after working a 12-hour shift, you want to try to get out of there on time. So it's an imperative that you arrive promptly. We ask that everybody arrive at least 10 minutes early to make sure that you've been able to get your papers in order, be able to take some notes, and be able to be ready to take sign out from the off-going shift promptly at the 7 o'clock hour. Wednesdays are never considered a day off on the ED rotation. We ensure that you have enough other days off, that you're going to have probably more days off than you do in a typical month on some of the other inpatient rotations. But our Wednesdays are our didactic lectures. We hold them starting at 7:30 a.m. until 12:30 p.m. in the Shock Trauma Auditorium, and we expect everybody to be there regardless of what your specialty is. A lot of emergency medicine can affect other fields, and at least especially with the acute resuscitation of patients, so I'm sure that you can get some benefit from these lectures. We try to make most of our lectures on the national level, so there's always cutting edge information being shared, so we expect to see you there. At 12:30 we have lunch that we provide for you, and if you're working a shift, we'd expect you to be ready to start your shift at 1 p.m. You do not need to come in on Wednesdays if you're scheduled to work. You can go directly to the Shock Trauma Auditorium at 7:30. If you do get sick and are unable to work, it's an imperative that you call our EM chiefs and let them know. Their phone number is on Amion. You could also page them through the BEEP operating system. But it is unacceptable to email them or text them. You need to make voice-to-voice contact. Depending on the specialty, we might be calling your chiefs so that they can have somebody come in and cover for you, or we might have to arrange coverage. But the earlier you can tell us, the better, because as you see, we need pretty much everybody that we have scheduled in order to take care of the vast amount of patients that come through our ED. So let's talk about how the ED runs. Patients coming through our triage, they'll be triaged by our nurse. Through part of the day, we have doctors or nurse practitioners out there helping triage them, and we'll either route them to the ambulatory zone side, which is our fast track. We stopped calling it urgent care because everybody thought they needed urgent care, and then they'll come to the main ED. Once they're designated to the main ED and a bed opens up, the charge nurse will determine whether it goes red or blue side, and that's a lot of times based on who just has an available bed. So our ED is split into two teams, red and blue. Blue team gets rooms 1 through 10, and red team gets rooms 11 through 13. Every team is headed by an attending physician, and then there's an upper level resident, PGY 2 or 3, who will see all the patients on that side and help manage your patients in addition, and then you'll see patients on that side depending on how busy you are and how sick the patients are. Our ambulatory zone team is called our yellow team, where some people are referring it to gold. It is staffed by an attending physician and a resident or intern, and also nurse practitioners. During the week, there's 2 shifts, either 7 to 3 or 3 to 11, and on weekends we do a 10-hour shift from 10 a.m. to 8. This team also covers our CDU, or Clinical Diagnostic Unit, where some of our observation patients go, and also boarders for the other teams. So a typical day in the emergency department. Your shift will start about at 7, and you'll get sign out. So plan, as we said earlier, to arrive early to prepare for sign out. For patients that are still active in the emergency department, being actively managed by us, have not been admitted to a team, and the care has not been assumed by a team, please complete a transfer of care note. This will be a brief note where you'll summarize the history of the patient and then pretty much create your to-do list, as you can see here, looking at labs, x-rays, CT, MRI results, and there will be extra space located below where you can actually write that you followed up on those and what you're going to do with those results. You can finally put down what the final disposition of the patient was, whether they went home, got admitted, transferred to another facility. But this note will give you a lot more space in order to be able to write that you assumed the care of the patient and took care of them throughout your shift. Once you've said hello, typically you and your senior will go around and see all the patients, just say hello to everybody, make sure nobody's acutely ill, and then you'll pick up a chart from the box and then sign up, see your first patient. In FirstNet, which we'll show you later, we ask that you do sign off for your patients so the attending knows which ones you're primarily seeing and which one the senior's primarily seeing. It also really helps the seniors and nurses know who to come to ask for, to put in orders, treatment questions. That'll make your life a lot easier if your name's up on the board. After you see a patient, it's imperative that you discuss the case with the senior resident or the attending. Most of us will allow you to do whatever you want with the patient, though we don't do some testing that we don't get the results back while the patient's still in the ED. So we're not going to get zinc portoporphyrin levels or lead levels or some tox levels because they won't come back in the ED. A lot of that stuff can be followed up or done as an outpatient. But discuss the case. When you discuss it with the attending, really have a good differential in mind, what you think is wrong with the patient. And a good way to think of that is SPIT. State what you think is the most serious first, so that's the S. P is what you think is the most probable. I is an interesting one. And T is treatable. But always list the most serious things first. So if it's chest pain, you're going to list that you think it could be ACS or PE, a dissection, and you can quickly give reasons why you don't think it's that, and then say what you think is the most probable diagnosis, and then state what you want to do for the patient. For your education, it would be best if you don't look at the orders in the computer system. Our triage docs are putting in orders. A lot of times they're not absolutely correct, and they can kind of lead you down the wrong path. So examine the patient yourself, and then go think about what you'd want to order, see what's been done, and then you could talk to the attending and senior about what else you think really needs to be done for the patient. At any time, if you're seeing a patient and they look really sick and acute distress, need an intervention quickly, please let the senior attending know so that they can get in there and you can start resuscitating the patient immediately. To help make you more efficient, please grab a T-sheet. That's our documentation paperwork, and we'll show you what some of the key parts of that look like in a second. But fill it out while you're interviewing the patient. It'll help prompt you to ask some of the questions. It'll just make you more efficient too than coming out and having to rewrite it. One of the most important things in the ED, though, is not going to be just seeing new patients and taking histories, but is to ensure that you're following up on the patients. So if you order labs or imaging studies, make sure that you're following up on the results of those and changing the plan based on that. If you gave medications, go listen to the patient again or make sure they're getting a good response to the pain. But make sure you're following up with them just so you know what's going on. And then you can change your plan accordingly. When ordering any radiology studies, please just check with the senior first. We have different ways of ordering stuff in the emergency department. For instance, we only give oral contrast for CAT scans of the abdomen and pelvis for 4 reasons. Everything else just needs IV contrast, so you can save a lot of time. Radiology will typically order the oral contrast, but you should know whether it's being done correctly, so just be careful what you're ordering and just run it by them real quick. You'll catch on pretty quick. If you're interested, the only 4 things that we use oral contrast for now is if we don't really know why we're getting an abdominal CT, but they just kind of need one. The second is if they're post-op, so that they can tell the difference between abscess and bowel. The third is if you think they have Crohn's or ulcerative colitis, it helps see the inner intestinal wall and look for fistulas. And the last one is cancer, if you're looking for an intraluminal mass. If it's other types of cancers, you're not really worried about colon cancer, you don't need the oral contrast. Last thing, just remember nurses are a huge part of our team. They've been doing this for many years and will save us many times. So if they're questioning you about a medication order or asking your advice about something, just think about it for a second and make sure that they're not really helping save you by catching a mistake. Throughout the shift, we recommend that you are running your list with the seniors every couple of hours, but definitely around 6 p.m. Make sure that you run the list one last time with the seniors so you can get a final to-do list and so you can try to wrap things up as much as possible by the time you sign out. For medicine residents, your RSC is adamant about that you can only work 12 hours, that they do not allow any time for sign-outs, so you need to promptly leave at 7 o'clock. You will not be able to sign out your patients to anybody else. So make sure all your work's done, including notes, and wrap up by that time, and then you'll have to leave. Other specialties can definitely stay for the sign out, which is extremely important for patient safety reasons. For a great rotation, please make sure you run the list every couple hours with the senior resident just to make sure everybody's on the same page. If you don't know why something's being done, it's completely appropriate to ask. Should it be done? Why is it being done? If you have a plan and somebody else wants to do something differently, like most things in medicine, there's no right or wrong, but there's a different practice style, so ask about that. Most attendings, if it's just a different style issue, will let you do what you want to do, but ask about it. When talking to people, always write down the time that you spoke to somebody and their name. So that way, if there's big delays in consults, which we definitely do have at times, we can go back and look and say, well, I talked to you at 1, it's 4 o'clock now, how come you haven't come down to see the patient? Sometimes people want to just say that they're like ortho or neuro, but get their real name for it. And a lot of times it's easier to do that if you let them know your name first. But I can assure you, after doing this for many, many years now, nobody's actually ever named their child ortho. But it's definitely our policy. If they refuse to give you the name, then let your senior know or the attending know. People need to be sharing their names. So our T-sheets are complaint driven. This is where we keep the T-sheets, as you can see on the picture on the right. And the upper left starts with trauma complaints, and it's supposed to be the head of the body working its way down to give you an idea. About halfway through the third column, it switches to medical complaints, again starting at the head and working its way down. So if you know it's something like an abdominal pain, it's probably going to be in the fourth column about midway down. You'll eventually get to know where most of the T-sheets are because a lot of the complaints will be used, but they're complaint specific, so if somebody has low back pain, grab that sheet. It'll really help you fill it out. If you don't know why or they have multiple complaints, then there's a general sheet that just has lots of blank space that you can go crazy with. But the T-sheets will actually help you ask pertinent questions and document a good story. Make sure you date and time the back of it, and if your signature is as bad as mine, print your last name. Again, taking ownership for your work, but people need to know who's writing it. The better your chart's written, the easier it is to read, the better off everybody is. Before you discharge your patient, please make sure that the senior resident and the attending have had a chance to review the chart. A lot of times that's how they make sure that their notes on the chart, and also to make sure that all the documentation is consistent. When looking at the T-sheet, you can circle for positives, but if you want to mark a negative, you got to do backslashes. And this is because sometimes if you do the forward slash in the opposite directions, we don't know if it's truly a check mark or a misplaced backslash. Or it sometimes looks like just a misplaced check mark. So if something's negative, put a backslash through the word, and you can check normals and circle positives. So this is what the back of a T-sheet looks like. So except, for instance, if there was no infiltrates and you saw one, you could put a backslash through it to say that there was infiltrates. We ask that you fill out some labs. You do not need to fill out everything, but you can say like normal except the glucose was 500, and then or just write in the troponin. But write in really pertinent labs. If somebody came in from dialysis and you're concerned about hyperkalemia, then you should write in the potassium was only 4.2. So write in the real pertinent ones, but you don't need to fill in everything. Cerner will show it, but you're just trying to show in your documentation that you actually looked at the labs and addressed them. There's always some progress note areas on the T-sheet. So this is great to write a time and say that with how they responded to their pain medicine, or they were able to tolerate food, or able to walk, or how they improved or stayed the same in the department. Doesn't need to be long, but you should always write a little bit of a progress note to say that things are changing. The last part of the T-sheet on the back is going to be your clinical impression. So this is the diagnosis that you're sending them home with. Not what you're working them up for, so not your full differential, but this is when you're finally sending them home, what you think the final thing was. So you can circle if they had a stroke, circle if they're having an MI, whatever it is. And if you ruled out certain diagnoses, so if they came in with a cough and you were thinking they had pneumonia but they don't, you could put a slash through that, say there's no pneumonia, and then write in like bronchitis. And don't be afraid to include multiple diagnoses. So if they have bronchitis and then hypokalemia or some other, they're also complaining of back pain, write them all down, all the diagnoses you're giving them. And these should match kind of like the discharge instructions that you're going to give them. Finally, you're going to write the time that you're going to send them home when you got them admitted. We use home for people that are discharged, OBS, if they're being admitted to like an observation status. Transfer is to another facility or unit, and then admit is a full admission. And then typically always check stable. Stable means that they still don't need to have an emergency condition that requires like more aggressive treatment, that it's safe for them to go to the floor to the unit at that time. And then this is the name of the attending that you spoke to. Up here, discussed with doctor, that's going to be if you discussed with like one of the medicine attendings or neuro attendings, you can write that in there. So we use FirstNet, we don't use PowerChart. And these are the different fields that you'll see. A acute is the entire main side of the ED, red and blue. But then you could also break it up so you only see your red team or blue team. ON is for overnight because it'll incorporate some of the yellow team beds into it that the red and blue attending cover. But if you just stuck with blue or red and don't even worry about the overnight, you'll be fine. You'll see all your patients you need to be. And then if you're on our yellow team, that's the ambulatory zone. So when you fill out and click on a patient, and then by clicking on a patient, if you click this little face here, that's kind of grayed out. But if you are on a patient chart and click that little face, your initials would show up in this column, so we would know that you were seeing a patient, just like CT has done. So sign up for the patient. You can also right-click here, and then, sorry, I actually did it instead of just saying it. But if you right-click here and say Assign Provider, it'll also assign your name to it. This column here is the case manager's column. They'll say whether the patient admits of observation status or admission status, and that goes important when you're placing orders. Observation orders should be placed by the team that's accepting the patient. Otherwise, they can't really bill for the admission or the observation. So observation orders we should not be putting in unless the accepting team has taken more than 30 minutes to put that order in, and then we can put it in. Without that order, patient placement never knows to find them a bed, and the patients would just linger in the ED forever. So the medicine surgery teams have 30 minutes from the time that you discuss and they accept for an observation patient, and they have to put that order in. If it's an admission, then you could put the order in. You just need to know who their attending is and who their team is. And then the notes section here in this column is typically where we'll write in waiting for CT, waiting discharge, waiting for a GYN consult, or who they're admitted to. So various notes will go there, but and you'll see that change. One of the things that can definitely make your life easier in the ED is our power plans. So if you go into orders and type in AED, you'll get a long list of our power plans. Power plans are in yellow, order sets are in white, but they're chief complaint driven, and in them you'll find lots of the labs, medication orders, x-rays, CT scans that you need to get instead of having to search for them. One of the really helpful ones is procedure labs. If you do an LP, an arthrocentesis, paracentesis, procedure labs has all those broken down based on procedure to make it real easy to order all your laboratories. The other one you need to know about is AED Meds to Go, right up here, This one, we have a certain sets of medications like doxycycline, Bactrim, Macrobid. There's a few others where you can go in there, click, and then give the patient a week's course of medication to try to help cut down on their returns to the ED because they can't afford their meds. So if you're given antibiotics and you don't have insurance, AED Meds to Go is a great way to get them some medications. And then we also have CDU observation orders. So those orders will be good if you're putting somebody in the CDU for chest pain or cellulitis. Those will have all the next day labs. One of the orders that you're not seeing here when they search for AED is AED Discharge. In our emergency department, we don't have to answer all those MOLST questions that you guys have probably been answering a lot when you discharge patients. So if you do AED Discharge, it doesn't ask you those because it knows it's coming from the ED, and we're exempt from that by law. One of the things that can definitely make your life easier is if you do put in the same orders frequently, like Dilaudid antibiotics. If you right-click on them before you sign them, you can add them to favorites. So that way when you do your order screen, all your favorites will pop up and you can just click on them, and it really makes it a lot easier. Before you click on add to favorites though, make sure all of the questions are answered. So that way it gets saved that way. If you don't have the route filled in for like a medication, you'll have to fill that in each and every time. So fill in all of the order specifics right before you're ready to sign it. Right click, add to favorites, and it'll really help you a lot throughout your residency. So patient dispositions. The various ways that patients can leave the ED. One is discharged. And when you do that, you're going to put in the AED discharged order. That order can also be used and should be used if somebody expired, because that'll be one of the choices in discharge, or if they left AMA against medical advice or eloped, they should still get a discharged order. And if they get discharged to University of Maryland Midtown Campus or another hospital, since they're leaving our building for the order, it's considered a discharge, but in that order you can actually say that they went to another institution. You can also put them in observation status, like when they go to our yellow team or to another service. We can admit them to an inpatient service, and then we transfer some of our patients to the psychiatric ED. They do not get discharged from the ED, they get transferred over to PES. But those are all of our dispos. So for admission, there's lots of different services that we'll just briefly talk about that you could potentially admit people to. Medicine has their general med teams. There'll be one med team on per day, meds 1, 2, 3, and 4. You just basically just need to call the on-call medicine resident, which is IMED, I-M-E-D. Discuss the case with them, get their attending's name if it's a full admission, or ask them to put the observation order in. But get their attending's name again, because if they take more than 30 minutes, you can put the order in. Teams are closed to admissions between 6 and 7 to allow them to sign out and switch over from day float to night float and night float to the daytime teams. So don't waste your time calling between 6 and 7. But that means during the 5 o'clock hour, really let them know if you have any admissions pending, so things don't slow down in the ED. If it's a transplant patient, and by transplant I mean below the diaphragm, kidneys, liver, pancreas, they can be admitted to Med 5, the transplant medicine service. Sometimes Med 5 is overwhelming with patients, and then we'll admit them to the transplant surgery service. The Med 5 attending will tell you if that's the case. Med 6 is a hospitalist service, and their pager number is Med 6. They'll take straightforward cases, chest pain, mild congestive heart failure. They do a good job of admitting a lot of the GI medicine service patients, and they coordinate all the transfers to the Midtown Campus. So if you have somebody that's willing to go to the Midtown Campus, the old Maryland General, Med 6 is who you call. They'll do all the paperwork, make the arrangements, make sure they have a bed over there, and handle the transfer. If you have an oncology patient, you can try the cancer center first. Unfortunately, the cancer center is normally full, taking scheduled admissions for chemo, but they will always take a neutropenic fever. No matter what, they'll take a neutropenic fever. All the other cancer patients should probably be admitted through Med 8, the oncology hospitalist service. And so you'll call them for that. Med ID is our HIV service, but they'll also take any patient with a confirmed infection. And that depends on their team census. Lately, it's been really good, and they'll take most patients. So if you have a patient without HIV, with pneumonia or cellulitis, then call MedID, and you probably can get the patient admitted to that service. They will always take HIV patients, even if they have chest pain and non-infectious disorders. So if they're coming in with rhabdo, chest pain, bad headaches, whatever it be, you can admit to the MedID service. Failing medicine accepts their own patients. So always ask to make sure that they're not a failing medicine patient, and you can also look it up on the computer. Occasionally, they'll take some unassigned patients, but just think of failing medicine if it's one of their patients. Neurology will see everybody for strokes, mental status changes at times, and also for like seizures, so consider them. Cardiology service will take people with advanced heart failure, people with LVADs, pulmonary hypertensions, and chest pain. Typically, they are so busy that the only chest pains they'll take is positive troponins, like non-STEMIs, but keep them in mind. And then Med 7 is our IMC service, and then there's finally the ICU services. And that's all the medicine services. Now switching, you also have the surgical services. The ACES pages, the Acute Care Emergency Surgery Service, is 84,000 as their beeper. When you page this, we really should be putting into it whether it's an urgent, like they need to be in the ED now. It's urgent, they can wait, or emergent, they need to be in the ED right now. What the patient's name is and what the reason for the consult is. Because when you page it through this number, their attending, their senior resident, and their intern all get the page. But they'll come down and see the patient. So this is anybody that has an acute abdomen. They've also been taking a lot of patients with pancreatitis. So consider them. MIS is minimally invasive surgery. There's also surgical oncology. And then you can call the surgical admitting officer for any of those patients. Transplant surgery will typically admit transplant patients up to 3 months post their initial placement of the transplant. Otherwise, they go to Med 5. And then if it's heart or lung transplant, hearts typically go to cardiology, lungs typically go to CT surgery, and some of that will depend on how long they've had the transplant. And then ask your senior resident about that. And then we have all the other subspecialty surgeries, whether it be plastic, ortho, OFS, urology, vascular. The clerk can page any of those services for you. A lot of times, though, they're covered by one person that covers multiple services. So it'll be the urology, plastics, vascular, intern. So expect any one of those people to call you back. Our case managers are there most of the day, and they'll look at the patient's history, complaint, and make the distinction whether they meet observation or admission. This is purely an insurance-driven decision, but it really affects us in the hospital. If you admit somebody that only made observation care, the hospital cannot get paid. But you can always place somebody in observation and up it to an admission. So if you ever in doubt, have the team put an observation order in. They have 30 minutes. They don't put the observation order in. You can do that. But it's a lot easier to go from observation to admission. You can't go backwards. So ever in doubt, it's observation. If you definitely see admission up on the board, and admission's definitely for ICU players and stuff like that, then you can do it as an inpatient admission. For AD observation, this you should discuss with your senior resident and the attending, but this is our clinical decision unit. We tend to take patients like with chest pain that need a stress test the next day, cellulitis, abdominal pain, allergic reactions, intoxications that we expect to be there definitely 23 hours or less. So we'll offload a lot of the inpatient services by seeing these low acuity people that just need a little bit more time in the ED. It also helps empty out the acute beds and puts them into our observation beds so we can see more of the patients that are in the waiting room. We can do stress tests on any non-holiday, non-weekend day. So we preferentially take all the chest pain. If they have a positive troponin, they should be going to cardiology. And so all chest pains, regardless of age, regardless of risk factor, should probably come to the CDU first. And if the CDU doesn't feel like they can handle them, then they can get admitted to an inpatient team. And that's weekdays when the stress lab's open. Our Midtown Campus, the old Maryland General, this is going to be playing like the dating game. So you need to ask everybody if they're interested in going to the Midtown campus. You're going to get a lot of no's, but occasionally get a yes. Our Med 6 attending staff, so University of Maryland Medical Center attendings, actually staff Maryland General now. We have Med ID attendings over there, and our ICU is also run by the same attendings that run our ICU at the University of Maryland. So for any of these services, if the patient's willing to go there, then call Med 6 if it's a general floor or teleadmission, call Med ID if it's HIV, and then call the ICU MICU fellow if you think they need to go into the ICU over there. They'll all come down, see the patients, and arrange the transfers if they are acceptable. Now, if the patient's going to need specialty care, one of our surgeons, CT surgery, something that Maryland General does not have, then they should definitely stay at University of Maryland. If they can't consent, they're not verbal, they're unconscious, family's not around, then you can't transfer them. The patients definitely have to be able to consent to the transfer. You can't just send them there even though they didn't have a chance to refuse. PES is our psychiatric emergency department. After medical stabilization, so if there's any medical condition at all, we have to see the patient first in the adult ED, or if we're not sure whether this is like just delirium versus dementia, we have to figure that out on the adult side, and then once we fix their medical condition, then they can go over to PES. So a lot of patients with hyperglycemia will come to us first, we'll get their sugars down, and then they'll go over to PES. Before going to PES, you need to call the PES resident, and the phone number is 1219. And then you'll write discharge instructions for the medical part of the visit. So don't print them out. We don't discharge the patient. We transfer them to PES. But just put it into the Cerner system that what instructions you'd want the patient to have for their hyperglycemia. Maybe not eat so much candy and drink plenty of fluids. Whatever you want to give them, but put that into the system. Speaking of discharge instructions, this is all due through FirstNet and Cerner. You probably have done some already on the inpatient wards. So because we do so many discharges in the ED, we can actually save a couple of steps for you. But as you know, the discharge instructions are really there to explain to the patient what happened throughout their ED. And this really needs to be simple language. So you can't use big medical terms, but try to keep it at the 3rd to 5th grade level. And it's kind of like a mini discharge summary too for us, so that way we know what they were in the ED for. In the discharge instructions, we should definitely put into it what their x-ray results or CT scan results were, so that they can share those with their private physicians too. So if you click on the patient's name and then click on the word depart, you can start doing the depart process. In the ED, we are not responsible for filling out the med rec, the diagnosis, or the disposition. So all you have to do in the ED is do patient education, where you're going to choose what their final diagnosis was and give them those instructions. You'll have to give them any prescription meds, and then when they should follow up. But again, you do not need to do med rec, diagnosis, or disposition. You can search as you do upstairs for any of the things. We're really finicky about making sure you fill in all these blanks. Part of it is just my fear of how we would look if somebody posts this up in a courtroom and says, "Oh, you were so concerned about our patient. Why didn't you tell them what temperature they should come back at?" So go through these. All if you have to do is double click on the line and write in the temperature that you want them to come back for. For follow-up, everybody should have some follow-up. They should follow up with their PCP in a week or two. If they don't have that follow-up, then tell them to return to the ED. And then there's one of the choices is if you have any concerns at all. So always click return to ED if condition worsens. We also, in this follow-up box, which is just a little bit above what's shown in this picture, is instructions to follow up. Please type into that any pertinent radiology findings. So if they had a CT of the chest that showed a benign nodule, just write it in there. It really helps our QA process if you type in what those radiology findings are, so they know that you are aware of them and they don't need to go out of their way to tell the patient about some incidental finding that you already knew about and didn't think needed to be addressed. So please type that into the follow-up. So good discharge instruction should definitely start with something like, you were seen in the ED today for your belly pain. We did a bunch of labs that were normal. A CT scan did not show any pain. We expect your pain to get better. If it doesn't get better within the next couple days to weeks, please follow up with your doctor or return to the ED, and definitely return if you're getting worse, so fever, vomiting, abdominal pain. You could also copy and paste a whole CT read-in if you want to include that for them. Personally, I print out the CT read and send it with them, but you can include it in the discharge instructions too. Just a quick word on procedures. You're going to get the opportunity to do a lot of procedures in the ED, whether it be LP, central lines, arterial lines. The consents for the procedures are obtained from the unit clerks if they already have the patient's name on it. But make sure you do a consent for all the procedures that you do. Your senior residents should be there at all times during the procedure, at least for the first one, and then if you are really comfortable with that. But it's always, each senior, make sure that that they're comfortable with you doing it. The attending has to be there for the key portion. So if you're doing a lumbar puncture, you can be in the room, prep the back, numb the back, but just as you're about ready to pass the needle, the attending should be around. At least let the attending know when you're doing the LP. It's their responsibility to make sure that they're for the key portion, but they can't get there if you don't let them know that you're doing it. And then make sure you write a procedure note. We have separate T-sheets where a lot of these can be done, but every procedure needs to be documented. Just a couple of miscellaneous things to do. Ultrasounds and MRIs are not read by our trauma radiologists, so the only way you can get these results is in impacts. So if you order an ultrasound, just keep checking the impact system for the preliminary read, because that's all we'll get until the next day. On Friday night and weekends, call the radiology resident and make sure the ultrasound tech's in-house, because sometimes they're not. They take call, and then the ultrasound won't get done unless we call the radiology resident and let them know it needs to get done. So Friday night and weekends, call the radiology resident if you order an ultrasound, just to make sure that somebody's going to be aware that it needs to be done. The most important thing is, please enjoy your time in the ED. I think you could do this the most easiest and get the most out of it and feel like you're in control of the patient the most if you just pick up that triage note, go see the patient, discuss the case with the attending, and then say all the things you want to do. It's not unusual that the triage doc has already got something started, but just realize they haven't spent the same amount of time as you actually interviewing the patient and examining the patient, so very often they miss a lot. But if they got some labs done that can make your job a little bit easier and help you narrow down your differential, that's great, because it decreases the amount of time. It didn't make their time in the waiting room all for naught. So take ownership of your patients, follow up. You can do a lot during this rotation, and we're here for you. If you have any questions or concerns during the rotation, the chief residents are there. I'm always available. Again, this is Michael Bond, the program director, and Mike Winters is our clinical director for the ED. He's always around and available. Finally, if you feel like that we're not open enough to the suggestions, please let your chief residents know or your program director. We're always trying to make this rotation as best as possible and a good educational component. So again, remember, Wednesdays, never a day off. If we expect you to be in our lectures unless you're coming off the night shift, and even then, try to come for the first hour and then go home and get some sleep. But you'll really find that our lectures are quite good, and I think you can learn a lot from them. I hope to see you in the ED. Have a good night.